So let's get started. I want to welcome everybody to this week's Grand Rounds. For those of you who don't know her, I'd like to introduce Dr. Stephanie Kletke. Dr. Kletke is a recent graduate of our program at the University of Toronto, where she graduated with the Wojciech Cup for having the highest academic standing over 5 years, as well as the KI Surgical Award for competency in cataract surgery. Following her training with us, she went on to the Children's Hospital of Pennsylvania, where she completed a fellowship in pediatric ophthalmology, and then returned to Sick Kids for a retinoblastoma fellowship, where she's now on staff. So we're truly excited to have Stephanie back in the department and to have her present Grand Rounds today. Stephanie, I'll hand it over to you.
Thanks so much, Amandeep. So good morning, everyone. Today we have about 3 cases to get through. So I'll hand things off right away to Michael Newen, who's going to do the first case. These are all cases, basically mimickers of retinoblastoma that are important not to miss. And this is applicable not only in pediatric ophthalmology, but you can imagine some of these patients perhaps presenting to your general practice as well. So go ahead, Mike.
Thanks so much. Good morning, everyone. I'm Michael Nguyen, one of the PGY5 residents. And I'm very excited to be here this morning presenting this very interesting case. I'd like to thank Dr. Kletke and the rest of the Sick Kids team for their really expertise in retinoblastoma. I think we're very lucky as residents to be able to train in a program with so many subspecialists. The title of my talk is No Leukocoria Here. And the objectives of my talk this morning are really to discuss an atypical presentation of retinoblastoma. And I want to review as well the differential diagnosis of hypertensive uveitis. And finally, I'm going to be talking about something interesting and exciting called aqueous humor cell-free DNA genetic analysis. More on that later. We'll start with a case presentation for a 13-year-old girl. And I'd like to draw everyone's attention to the fact that she's 13 years old, not months. She comes into Sick Kids Clinic with a 2-week history of a right eye pain and redness. Her review of systems is unremarkable. She's otherwise healthy and has no relevant family history. On her initial examination at Sick Kids, her visual acuity is 20/20 in both eyes, and her IOP is elevated in the right eye at 41. The left eye is 14. Looking at her anterior segment examination, we see that her right eye cornea is clear without any cratic precipitates. The AC does have a marked 3+ cell reaction without any presence of posterior synechiae. But on gonioscopy, we do notice that she has 270 degrees of peripheral anterior synechiae. Looking at the anterior vitreous, we do not see any presence of vitreous cells. The left eye is within normal limits. On our initial dilated fundus examination, we see that in both eyes, she does have a normal disc, macula, vessels, and periphery. And importantly, there were no white retinal lesions seen. At this point, we have a 13-year-old girl who comes with red eye and pain, as well as high IOP and an AC reaction. Thinking about our differential diagnosis for hypertensive uveitis, we of course first think of the herpetic causes. These include herpes simplex 1, 2, and varicella zoster. Another potentially virus cause is from CMV. There is this entity known as Posner-Schlossman syndrome, which is characterized by acute unilateral recurrent attacks of very elevated IOP, but with a mild AC inflammation. It is thought that this condition may also be associated with the CMV. Another potential virus cause is from a rare condition called Fuchs heterochromic iridocyclitis. And this is a condition that is classically associated with the rubella virus and is characterized by iris heterochromia, low-grade inflammation, a fine stellate KP, cataracts, and iris rubeosis. For the residents who are studying for their exams, we also know of a sign called Amsler's sign, which is the presence of hyphema after an intraocular procedure due to rupturing of these friable iris vessels. Of course, idiopathic is always in the differential for uveitis, and we know that that is, in fact, one of the most common causes of uveitis. But in any differential for uveitis, we always must keep in mind the masquerade syndrome, especially malignancy. No matter how young or how old or how not young or old the patient is, we always must keep in mind that this could be the diagnosis. This patient was initially managed as a hypertensive uveitis patient would be, with prednisolone 1% drops every 2 hours, some steroid ointment at night, cycloplegic drops, glaucoma drops, and some oral acetazolamide to control the pressure. She also had a uveitis workup sent for syphilis, Lyme, toxo, TB, ANA, and rheumatoid factor. I'd like to remind everyone that in the pediatric population, getting ANA and rheumatoid factor is very important because this has implications for diagnosis and prognosis. Whereas in the adult world, we know that ANA and rheumatoid factor are much less helpful and can sometimes even muddy the picture. But in the pediatric population, it is absolutely essential to get this. 1 week later, she comes back to clinic and her vision is still preserved at 20/20. Her IOP has been appropriately treated and is down to 16, and her uveitis workup so far has been unremarkable. On close examination of the patient, and we now see at her iris that there is the presence of this solid, elevated, spherical anterior chamber nodule found nasally in the patient. And admittedly, this is hard to see. It's right next to the yellow asterisk over here. But when we got an anterior segment OCT, you can see that it does really show this lesion much nicer. There is the presence now of the solid round lesion. We can also get that it is homogeneously solid, i.e. it's not cystic, and it is a lesion that is in fact separate from the iris and not part of the iris stroma itself. Looking at the fundus again, we now see that there is presence of the supratemporal vitreous debris. This is in the vitreous, not in the retina. And importantly, the rest of the retina does not show any retinal white lesions. This is an artifact, and so is this. So the only abnormal finding here is the presence of supratemporal vitreous debris. Looking at her macular OCT, we see that there is good foveal contour, normal retinal lamination, intact ellipsoid zone, and a healthy appearing inner retina. Given all of these findings, we have decided to refer the patient to our ocular oncology team, and the patient was next seen under examination under anesthesia. This is what they found during the staging EUA. This is a RETCAM photograph, again, showing a normal posterior pole without any retinal white lesions. When they looked at the temporal pars plana, this is the lesion that they found. So to orient everyone, this is looking at the pars plana under scleral depression, and you can see now that there is this mildly elevated white pars plana lesion. You can also see here the presence of fine dust, and this is confirmed on UBM. I will walk everyone through this UBM, as I admit that UBMs are not a frequent part of our training in residency. And we see here that this is the sclera. This line that I'm highlighting right now is what should be the demarcation for the ciliary body. And this line over here should be where the anterior hyaloid face is. And between the anterior hyaloid face and the ciliary body, there usually should be nothing. But here we can see that there is this presence of this lesion, which corresponds to this lesion over here. This is here is the iris, and these are the ciliary processes. Next to the ciliary processes, we also see finding of a seeding, and this seeding can also be seen on another slice of the UBM over here. When we look in the far periphery of the lens equator, we can see there is actually presence of multiple seeding throughout the lens equator, 360. We did a MRI, which did not show any concerning findings. And at this point, we are concerned about a new differential diagnosis different from the one that I just showed you. Given these new findings, we are now, of course, worried about a retinoblastoma presenting in the anterior segment. We also want to consider a diagnosis of medulloepithelioma. And as a reminder, this is a tumor of the ciliary body, specifically of the non-pigmented ciliary epithelium. And of course, we should probably add pars planitis to this picture too, although this is highly unusual and unlikely to be snowballs and snowbanking, but it is technically part of our differential diagnosis. However, of these three, it was felt that the most likely diagnosis was retinoblastoma, and the patient was treated as such. This, again, is the same picture montage from the previous slide, so nothing has changed, but I'm going to draw your attention now to this graph on the left side. Most people are not familiar with this type of graph, but I'm going to walk you through it today. This is very commonly used in retinoblastoma at sick kids to provide a snapshot of the various treatments and visits that a patient has received through time. So on the x-axis is time. So as you go to the right, more time has passed. In between these two dotted lines here, the gray dotted lines, that usually represents 1 year of a child's course. And in between is divided to 12, so 12 different months and what their treatments were. The yellows represent various EUAs the child received. And I'm going to start off here by looking at these symbols over here. So the red circles represent systemic chemotherapy, and the child did receive 3 cycles of systemic chemotherapy with carboplatin, etoposide, and vincristine. And these green M's represent intracameral injections of a different chemotherapeutic drug called melphalan. During each of these intracameral injections of melphalan, there was also an AC tap, and the AC tap has the aqueous humor, which was sent to cytology to see if there were any malignant cells, but unfortunately, it was inconclusive. During one of the intracameral injections, in addition to taking an AC tap, they also performed a fine needle aspiration of one of these seeds, which is not usual and not typical for an RB case. This fine needle aspirate did show some malignant cells here, as you can obviously tell here, but did not confirm the diagnosis of retinoblastoma. In order for us to finally get the diagnosis of retinoblastoma, something else was done to the aqueous humor. So this was not looking at the cells, but this was looking at something called aqueous humor, cell-free DNA, and what the sequencing of that DNA showed was an RB1 gene deletion, thus confirming the diagnosis of retinoblastoma. 3 months after these systemic and intracameral treatments, we see that there is much improvement of the pars plana lesion here. You can even see that on the UBM. So again, this line here represents the anterior hyaloid. This line here represents the ciliary body, and in between is the lesion. And the lesion, you can see that there are now black spaces in between, whereas before there were much less. There is improvement even on UBM. The seeding also has improved greatly. So at this point, I'd like to talk now about the staging. This eye was considered to have group E or CT3B staging, and I'm going to talk about them now. So the first staging is group E, and group E comes from the International Intraocular Retinoblastoma Classification, or the IIRC. This was founded in 2005 and was a system used to predict response to chemotherapy. Group A has the smaller lesions where the eye is likely to be more likely to be salvaged, and as you progress down the groups, there is more advanced features. I remember that C represents seeding, so that's how I remember it for my examinations. And when we get to group E, these are really the atypical advanced features. Our child was considered to have group E by the IIRC because their tumor was anterior to the anterior hyaloid, as I showed on the UBM. The second staging system is called the AJCC, and this is where we got the CT3B system from. This is a more recent classification system founded in about 2017, and is now considered for us at SickKids the gold standard because it includes intraocular and extraocular features to allow for a complete staging of the child's retinoblastoma. 4 months later, after the treatment, unfortunately, we see that there is now some new recurrence. The pars plana lesion has gotten a bit bigger, and there is some filling up of the space between the anterior hyaloid and the ciliary body. And looking at the anterior segment, we do see that there is now some recurrence of some of the seeding, which is very hard to see on slit lamp examination, but shows up much nicer on the anterior segment OCT. And you see some more seeding here in the lens equator and periphery as well. So at this point in time, the child then received a chemoplaque, and a chemoplaque was done under phase 1 clinical trial. And this chemoplaque is also not a classic treatment for retinoblastoma. It's similar, but quite different from the radiation plaque that's used in ocular melanoma that we see at Princess Margaret Hospital, in that these are, of course, chemotherapy, not radiation. And this plaque is left on for much longer. So this chemoplaque was actually tissue glued to bare sclera and left on the eye for 6 weeks, compared to the 1 week that is often done for radiation for ocular melanoma. And this was on the graph here, the purple squares show the chemoplaque insertion and the removal. And here is the same picture montage from before. And we see that 7 months later, after the chemoplaque, there is actually much improvement in the pars plana lesion. It almost has this cicatricial look to it. And on the UBM, you see that there's also much improvement, again, of the lesion. The seeding also has improved as well. And this was 7 months, again, after the chemoplaque. Thankfully, we have data up to now 3 years later from her initial presentation. And thankfully, her best corrected visual acuity has remained at 20/20, and the regressed residuals have been stable with no evidence of tumor recurrence, extraocular extension, or any metastases. I would like to note that also at the last EUA, there was also this aqueous humor cell-free DNA that was that tried to be sequenced for the last AC paracentesis, but they did not find any cell-free DNA. So keep these facts in mind as I go through the rest of the presentation. Before I talk more about cell-free DNA, I'm just going to quickly talk about the condition of anterior diffuse retinoblastoma. This is a admittedly very rare condition. So this is, it presents 1 to 2% of all cases of retinoblastoma, itself already a rare disease. But it's important to keep this in mind, and let me tell you why. This is a commonly unilateral presentation of retinoblastoma that presents in older children. The mean age in the literature is 6. And you remember that our child was actually 13 years old, so much older than even this mean. And 13 is, of course, much, much older than how typical RB presents, which is only around the age of 1.5 years of age. As a result, it is often misdiagnosed as uveitis because there is no classic leukocoria that we're all trained to look for, and it presents instead as a uveitis, sometimes with atypical features, but nonetheless will lead to a delay in management. Thankfully, our team at Sick Kids was very astute, and we were able to catch this child quite early on because majority of these cases actually end up being treated with enucleation. That's why she was classified as having a group E staging for the IIRC, because that predicts eyes most likely to need enucleation rather than salvage. But thankfully, our child was able to be salvaged. Another question that people may have is, how did this child's retinoblastoma get so far anterior? Isn't there no retina in the pars plana area? Well, the theory for our child is that the pars plana tumor arose from this isolated ectopic ciliary retina. And as a result, there was seeding into the posterior chamber and to the vitreous due to perhaps an absence in the internal limiting membrane. Now I'm going to quickly talk about cell-free DNA. So cell-free DNA is a very exciting, it's not new, but it certainly is newer in retinoblastoma, and it is something very exciting. And I want you to remember cell-free DNA, and it can be thought of as using aqueous humor as a liquid biopsy for retinoblastoma. Now, as we know, retinoblastoma is usually a diagnosis based on clinical and imaging findings. We don't need to take tissue diagnosis to make the diagnosis of retinoblastoma. And that's usually the case when the retinoblastoma is very typical, when there is a white retinal lesion in a child with the appropriate age and other findings. However, sometimes in atypical cases, or even looking forward to the future, in order to monitor these children's retinoblastoma, we were wondering, is there a different way that we can do this? How this came about to be was that patients who usually receive an intracameral or intravitreal injection of the chemotherapy drug melphalan routinely receive an AC paracentesis beforehand. This is, of course, to lower the IOP, but for retinoblastoma, we also don't want to have reflux of seeds back to the injection sites. Since the researchers have extracted the aqueous humor anyways, they were wondering, could we use this fluid somehow other than for cytology? And as a result, they came up with using cell-free DNA analysis for the RB1 gene as a liquid biopsy for retinoblastoma. This picture will help explain what cell-free DNA is. So here is a classic retinoblastoma lesion with cancerous cells. Cell-free DNA here consists of DNA that is released by tumor cells through cell apoptosis. And this is usually free-floating DNA that's not protected in the nucleus as it is in usual cells. For you and I, if we checked our normal aqueous humor, we would not find any cell-free DNA because all the DNA in the aqueous humor should be in cells, if there were any. But here, the cell-free DNA diffuses from the vitreous into the aqueous humor, where a paracentesis can receive this and analyze them for any presence of mutations or deletions of the RB1 gene, as well as looking at the overall genetic signature. This proof of principle study was published in JAMA Ophthalmology in 2017, showing that the genetic signature of the aqueous humor cell-free DNA that was retrieved in vivo while the patient's eye before it was enucleated, and they compared it to after the child receiving an enucleation, looking at the actual genetic signature of the tumor itself, and they compared them and found that it was the same, thus proving that the aqueous humor cell-free DNA did indeed come from this tumor, and really shows the potential for the aqueous humor as being used as a liquid biopsy. So for my take-home points, I want everyone to remember that anterior diffuse retinoblastoma is a rare subtype that presents unilaterally in older children with tumor activity that is isolated to the anterior segment. There is no leukocoria, and there likely will not be when you see the children. It will most likely be a hypertensive uveitis or a uveitis. So be sure to keep malignancy on the differential, no matter how young or old or not young or old you think the patient is, especially when there are atypical features for their presentation. And finally, it's very exciting to hear about these innovations. And I'm sure we'll all be hearing a lot more about aqueous humor, cell-free DNA, genetic analysis in the future in its role as a liquid biopsy for both diagnosing and following retinoblastoma. Thanks, everyone.
Thank you, Mike. That was excellent. There's a question from Manlong here. Is cell-free DNA test available across Ontario or Canada? And what is the sensitivity and specificity?
So I can help with that. So thanks, Mike. That was a wonderful talk. So currently, as Mike highlighted, this is just done on a research basis. So even for this patient, this is the only child we've done this for diagnostic purposes. So if you can imagine, in most cases, as Mike highlighted, retinoblastoma is a diagnosis based on clinical and imaging findings. So we don't really need this test for diagnostic purposes. But there's a lot of research going on over the last few years in this area. The main reason we're looking at cell-free DNA is actually not specifically for the RB1 mutation, but also for the rest of the genomic signature of the tumor. That includes somatic copy number alterations, so chromosomal gains and losses. And the main reason we might be interested in that is looking for prognostication of tumors. So potentially looking at these specific copy number alterations and how they change over time with treatment, and whether they can predict the prognosis at presentation. So this was a unique case in which we used it for its diagnostic potential, but in general, most of the research is being done looking at prognostication of tumors and looking at whether cell-free DNA in the aqueous changes over time in response to therapy. So this was all done on a research basis. I think you asked about sensitivity and specificity. We don't really have that yet because it's not a clinically implemented test at present.
Stephanie, presumably this patient did not respond to the hourly topical steroid that you put this patient on. Was that what led you to think about a different diagnosis?
So when they came back, you're right. So they still had anterior segment inflammation. The IOP had responded on medical management, but the inflammation hadn't. And it was one of our very astute pediatric ophthalmologists who noted those very subtle signs in the anterior segment. But admittedly, it's actually very difficult to see those seeds even on slit lamp exam. So the anterior segment OCT was also critical to find that seed.
I think Dr. Galley has a comment.
Yeah, I'd just like to add that the sensitivity and specificity of this is well documented in published papers from many centers in the world, particularly led by Jesse Berry at Children's Hospital LA. We are not doing it clinically in Canada yet. We have all the capability of doing it, but we need to do some process to establish it here in Ontario. And of course, each province has to do their own genetic testing or the genetic rules. So we'll be close to doing that, but we must support the development of that at a clinical test level.
We're on the road to collaborating with Jesse right now.
But Jesse's collaboration only provides Jesse with more samples for research, does not give us a test to do in Ontario.
A couple more questions for you here. From Dr. Lichter, is the risk for future malignancy the same as maybe for an RB patient?
So we didn't chat about the rest of the genetic testing. So this confirmed a complete RB1 gene deletion biallelic, so at the level of the aqueous. However, we looked for that gene deletion in her blood and it was not present. So that suggests she has non-heritable retinoblastoma and therefore is not at risk of second cancers, if that's what you mean by future malignancies.
I think so. And you kind of addressed this already, but Dr. Epstein was asking if the case was really picked up from the iris lesion that was difficult to even see.
Yeah, that was the main suspicious finding, and also the lack of response to topical steroids or typical uveitis management. And honestly, all of these findings are much better appreciated during an exam under anesthesia when she's very widely dilated. We can see those lens equatorial seeds and also the ciliary body lesion. For children, it's very difficult to depress them in clinic. Actually, we follow her in clinic now and she tolerates it quite well, but you can imagine that that would be quite difficult. So the EUA was critical for diagnosis too.
And that anterior segment OCT picture you shared was quite striking. Dr. McAllister asks, do the anterior chamber cells look any different than normal inflammatory cells?
That's a great question. It's probably a mix of both. I don't think we can distinguish that at the slit lamp. Certainly the actual seeds do when they've progressed to that level, but I don't think we can distinguish between inflammatory versus malignant cells.
Thank you, Steph. I have a question.
Could I just comment that I remember very clearly in Camiar's office at 525 looking at that picture of that well-described little nodule on top of the iris that wasn't from the iris that triggered the thought of retinoblastoma. And to me, that was absolutely looked like retinoblastoma in Camiar, and I immediately changed the diagnosis from uveitis to retinoblastoma.
I mean, that's a fascinating case. I guess a couple of questions I have is, you mentioned that older children do get this anterior form, and the mean age is still 6. This child was still quite a bit older at 13. What's the oldest that the literature has reported this in?
I don't know the higher limit of the age, but probably in early teens around there. I mean, there are case reports of RB presenting in adults too, not necessarily this form, even the typical posterior segment form, but certainly rare.
Thank you. And just one more question. Mike, you mentioned there was an MRI done. What did you guys image?
So we imaged the MRI of the brain in orbit with and without contrast. That's part of our staging workup for retinoblastoma. And we're looking specifically for any signs of optic nerve involvement, any extraocular extension or intracranial involvement. For her, we didn't find any of those concerning features. In fact, I think all of the intraocular findings were so subtle that they weren't even appreciated on MRI.
Got it. Thank you. That was a fascinating case, Steph and Mike. Thank you for sharing that. And we'll move on to Ellie's presentation.
All right, perfect. I'll just get my screen up. Okay, and everyone can see that okay?
Yes, we can.
Awesome. So again, I'm Ellie. I'm one of the PGY5s here at U of T, and just wanted to thank Dr. Kletke for all of her help with providing these cases and putting the presentation together, as well as the team at Sick Kids for providing all the details about these cases. So let's just jump right in to retinoblastoma mimickers not to miss, round 2. So we'll start off with a 39-month-old boy. And this child presents with a 2-day history of right periorbital swelling, purulent discharge, and eye pain. The child is otherwise healthy and has no recent illness or witnessed trauma, and there's no known family history of retinoblastoma. And the parents do mention that his eye looked completely normal before he presented to hospital, and that although there was no witnessed trauma, the child does play unsupervised outside quite a bit. So the possibility of trauma couldn't be completely excluded. Additionally, the child looked otherwise well, was afebrile, had a normal white count, and here is what he looked like. So this child, unfortunately, was quite uncomfortable in the clinic despite some sedation. So the decision was made to perform an exam under anesthesia. And looking at the top left image, you can appreciate that there's significant right eyelid swelling, as well as this kind of hemorrhagic chemosis that's almost protruding out of the globe a little bit, or out of the eyelids. And looking at the images below, you can appreciate some hemorrhagic conjunctival chemosis, which is pretty well 360, as well as a diffuse 8-ball hyphema with no view to the anterior chamber or to the posterior pole. Now, interestingly, there was no evidence of a corneal wound or a conjunctival wound or any kind of open globe injury that was kind of obviously noted. Now, of course, we need to get a look inside the eye to see what's going on here. So looking at the top right, you can see a UBM scan that was done. And the kind of most obvious finding here is a dislocated or subluxed lens. You can see right here. And the other interesting thing to note is that the anterior chamber is still quite deep. So there's no kind of posterior pushing or any mass effect causing the anterior chamber to be pushed forwards. Now looking in the bottom right corner, this is a B scan of the globe, and this shows kind of a heterogeneous material which is filling the vitreous. And it's kind of diffuse. It's not entirely clear whether it's a hemorrhage or not, whether it could represent a mass. And then looking a bit further back, you can appreciate some thickening of the choroid and a few scattered hyperdensities throughout the vitreous as well. So just given this whole story, IOFB could not be excluded, especially with those hyperdensities in the vitreous. And additionally, the left eye was completely normal at this time. Now, given this presentation, the decision was made to undergo some imaging. A CT scan on the top was actually done at the outside hospital before the child was transferred in. And again, you can appreciate that there's some eyelid edema and proptosis. As well, if you look at the green arrow at the top, there's a possible error loculi there. And then inside the globe, indicated by the blue arrow, are again a few discrete hyperdense foci, which were thought to potentially represent calcium or some kind of intraocular foreign body. Additionally, there was fat stranding with periorbital soft tissue thickening in the right orbit. Now, given this, an MRI was also performed, which is the bottom half of the screen. And this is a T1 axial section. And again, is appreciated the marked proptosis of the eye, as well as hyperintense fluid in both the anterior and posterior chambers, which was kind of felt to suggest a hemorrhage in this case. Noted by the yellow arrow, you can appreciate this lens dislocation or subluxation once again. Now, given all these findings, the kind of prominent edema, the preseptal, postseptal edema, and oh, sorry, the other thing I should mention is there's this focal enhancement of the right optic nerve head, which can be appreciated over here. Now, given all these findings, the radiologist actually felt that this was most in keeping with an infectious or an inflammatory process, and that a neoplastic etiology was a much less likely. And the reason they felt this is that there was really no kind of evidence of a discrete mass on imaging, both if you remember back to the B scan and additionally on CT or MRI, there's really nothing to suggest a specific mass. Now, at this point, the differential was pretty broad. It wasn't entirely clear what was going on, and there were kind of features that were suggesting a few different differentials. However, the one that was kind of leading the discussion was a closed globe trauma. And this was given the significant chemosis, hyphema, the posterior lens subluxation, which would be something very unusual for RB, and as well as the minimal calcifications, which could represent an IOFB. Other things on the differential included a scleritis, and this was due to the severe pain, chemosis, choroidal thickening, and postseptal changes that were noted. Orbital cellulitis was also possible given the eyelid edema, chemosis, and the fat stranding in the posterior orbit. However, the child was afebrile, had no white count, and was otherwise well, so this was felt to be much lower down. And then lastly, retinoblastoma, given the intraocular calcifications, was felt to be possible, but again, everything else was kind of pointing towards a trauma at this point, and there was no discrete mass noted. So this child was admitted to hospital and was treated as a trauma case. And he was treated with the usual prednisolone, atropine. He was given some IV antibiotics as well and oral NSAIDs. And within a few days, interestingly, his pain reduced significantly. and the proptosis and the chemosis had essentially completely resolved, as you can kind of see in the pictures there. Still a little bit of conjunction, but significantly improved. At this point, the anterior chamber was also identifiable, and you could appreciate a little bit of a hyphema and clotted hemorrhage. So at this point, closed globe trauma was still kind of leading the way in the differential, and the patient was discharged on medical management with a plan for an EUA in a few weeks. Now, the patient returns in 4 weeks for this planned EUA. And here you can see a picture of the right eye. And again, noted as this kind of conjunction and congestion, but no obvious chemosis. And the AC is deep with some residual hyphema. Interestingly, the iris was kind of completely absent. So this was felt to potentially, again, be in keeping with some cause of traumatic aniridia. And as well, you can appreciate the lens subluxation here. One interesting thing to note was that during this exam, there was actually fresh active bleeding from the angle in the eye, which again would be a little unusual now at this point if it was a trauma case, because it's past the point where you would expect any significant rebleeding. A B scan was repeated at this point, which demonstrated some thickening of the choroid and sclera, as well as a residual vitreous hemorrhage with increased calcifications. And now there's this kind of area of possible scleral discontinuity, which you can appreciate with the blue arrow. And there was a concern that, maybe this could represent an RB that was starting to spread. However, given the fact that this child improved so significantly on the NSAIDs and his pain had improved, it was actually felt in this point to maybe be more in keeping with a type of scleritis or panophthalmitis. So the child was therefore started on oral steroids to try to further lessen the inflammation with a planned EUA in another 2 weeks. Now at this point, again, RB still on the differential, but much lower given the deep anterior chamber, the lens subluxation, which would be very unusual in RB, the ongoing lack of a definite mass, and a few calcifications, which were kind of, I guess, not particularly specific at this point. So the patient returns for their 6-week EUA with a significant increase in pain and redness despite the oral steroids, worsening of the conjunctival injection, and now has corneal edema and an epithelial defect. The AC is still deep, but there's fresh hyphema, and the eye's actually hypotenuse now. And looking at the B scan on the right, you can appreciate a disorganized posterior segment, again with residual VH and calcifications. And again noted is this area of scleral discontinuity at this point, which was quite concerning for an extraocular extension of possible RB. So given this whole clinical picture of worsening on oral steroids and the thought that this could be RB, the patient was in significant pain, and at this point the visual prognosis was felt to be quite poor. The decision was made to proceed with enucleation of this eye. And upon enucleation, there was a gross thickening of the optic nerve, and sectioning of the globe revealed a diffuse brown necrotic lesion inside the eye. Now, this is a bit different than the usual kind of big white RB tumor that we might be used to seeing. Moving on to the pathology, I'll just briefly touch on this, but there are 3 kind of things to highlight here in the pathology, which of course did confirm the diagnosis of retinoblastoma. So looking at the top screen with the blue square, so this showed massive choroidal invasion and intrascleral invasion along the ciliary nerves, noted up here. The yellow square is demonstrating extraocular tumor spread involving the perineural space adjacent to the optic nerve. And this is what we were seeing on those repeated B scans of that area where there is a hypodense kind of focus just adjacent to the optic nerve. And lastly, on the bottom, the green square, this is retrolaminar optic nerve spread as well. Now, the patient underwent a lumbar puncture, and this was positive for CSF involvement. He also underwent a bone marrow biopsy, which was negative for malignancy. So all these features with the high-risk pathology and the evidence of extraocular tumor, and as well as tumor in the CSF, put him in a very high-risk category of RB. So he was treated as such as a high-risk RB, and this involves many doses of high-dose systemic chemotherapy, orbital radiation, intrathecal chemotherapy, as well as a bone marrow transplant. And I won't belabor the details of the treatment too much, but the child actually remains disease-free 7 years out and just has some kind of minor socket complications related to this. Now, the main impact of this case here with the kind of confusing presentation and unclear diagnosis was the delay in treatment that potentially led to the extraocular extension that we noted in this case. Now, I'll just quickly move on to a second case. This is a 6-week-old boy this time compared to the 36-week-old last time. And this child is referred in on a Friday afternoon with 1 week of left leukocoria, otherwise healthy, and no family history of RB. When you do your exam in clinic, you note that the IOP in the left eye is quite elevated at 65. And here you can see a B-scan picture of both eyes. In the right side, there's actually a very small peripapillary tumor that you can see kind of just protruding almost beside the optic nerve. And in the left eye, the globe is essentially filled with tumor and scattered calcifications throughout. And interestingly, he also had a slit-like anterior chamber. So of course, imaging was also performed in this case. And you can see this is an MRI scan. And the radiologist noted a possible enhancement of the left retrobulbar optic nerve, which is indicated by the green arrow, but there was no obvious evidence of extraocular or intracranial involvement at this time. And there was no signs of periorbital inflammation. Now, of course, this comes in on a Friday afternoon with an advanced presentation, and given his high IOP, advanced disease, and this possible optic nerve involvement, the decision was made to proceed with an EUA and enucleation of the left eye on Monday. Now, a few hours later on the same day, the parents call in saying that the child has now developed this kind of significant swelling of the eyelid, this really red, bloody looking eye, and the child is now quite irritable. So of course, they come back into hospital. The child is otherwise afebrile with no white count, and you can appreciate the swelling and chemosis in the picture above. And a repeat B scan again showed the tumor filling the entire globe. And this was really done to just make sure that we didn't miss any obvious extraocular extension of the tumor. So given this presentation, it was felt that the child actually developed an aseptic orbital cellulitis secondary to the retinoblastoma. At this point, you could make an argument that you could repeat a CT scan or MRI to, again, look for any changes, but it was felt that this probably wouldn't change management. And we didn't want to expose the kid to any extra radiation with the CT given the heritable bilateral disease. At this point, the child was admitted for IV Diamox and some methylprednisone to decrease the swelling before surgery on Monday. And if you're wondering if this can actually develop this quickly, this is what the child looked like just a few hours earlier in clinic. From an inflammation perspective, essentially completely normal. So it really can happen just like that. So moving on to Monday, on the right side, you can see pictures of the right eye, and is demonstrated here as the peripapillary tumor, as well as an OCT through the tumor. And on the left side, you can appreciate the ongoing swelling of the eyelid, the incredibly narrow, almost non-existent anterior chamber, chemosis. And then looking at the UBM scan inferiorly, the AC is essentially flat and the iris and lens are pushed right up against the cornea there. So this is, a significant posterior pushing mechanism. And in this case, I just want to highlight that, although the left eye is very, very obvious, it's really important in these cases to do a good dilated exam in both eyes. Obviously, there'd be no view in the left eye, but it could be very easy to miss the small tumor in the right eye if you just focused on the left eye. So just wanted to highlight that it's very important to always get a good look at both eyes. I know Michael touched on the grading system, so I won't belabor it too much, but in terms of this child, His right eye was staged as group B, or a CT1B, indicating a tumor greater than 3 millimeters and less than 1.5 from the disc or fovea. And the left eye is graded as group E. The aseptic orbital cellulitis automatically kind of puts you in that high risk, most advanced group. And as a CT4A, you'll note here that aseptic orbital cellulitis would actually put you as a CT3E, but in his case, he actually had radiologic evidence that the tumor might be expanding into the optic nerve, putting him into the 4A category. So again, given this advanced disease, the left eye was enucleated and the child underwent systemic chemotherapy. And for the right eye, given the proximity of the tumor to the nerve, the goal was to shrink it a little bit with chemotherapy and then to do some focal laser to get rid of the rest of the tumor. If that tumor was much further away from the optic nerve or from the fovea, focal laser could have been done as a primary treatment, but just given its proximity, it wasn't safe. Now here's a pathological section of the left eye, and luckily there was no optic nerve invasion or choroidal invasion. So from a pathologic perspective, it was graded as a PT1 and appreciated as this extensive necrosis and inflammation of the intraocular structures. Interestingly, there was a possible thrombus in the kind of middle bottom picture in the slide of the central retinal artery occlusion, although this was inconclusive. There was also some pushing of the necrotic tumor into the optic nerve head, but this was thought to be due to increased pressure and not true optic nerve invasion. So overall, this kid actually had no high-risk features. In terms of the right eye, so this is just demonstrating the tumor after some rounds of chemotherapy, and you can appreciate that the tumor has now shrunk in size about 50% after 4 cycles of chemotherapy. And at this point, the decision was made to proceed with focal laser. Now, the bottom picture is the child after enucleation of the left eye, and just to show how he looks with the kind of orbital prosthesis in there. Just to summarize the discussion on the right eye, this is actually 2 years post-presentation, and you can see that laser has been done to that area. He actually had some recurrences within the scar and needed more laser and chemotherapy, but luckily it's all inactive now and he remains quite well and 20/20 vision in that eye. So what do both of these cases have in common? Well, they both presented with an aseptic orbital cellulitis. So this is a non-infectious inflammation of the periorbital structures. And this could be due to a variety of reasons, including but not limited to idiopathic causes, neoplastic, both intraocular or orbital, and traumatic causes. And rare causes include retinoblastoma. Now, interestingly, in the literature, this is more common in developing countries, and actually up to 5% of RB cases present this way in the developing world. And this is likely just due to a later presentation of disease. Now, when RB presents in this manner, it's often associated with a very large tumor size, possibly neovascularization of the iris, as well as ciliary body necrosis. And you might recall that one of the second case presented in hypotony, likely due to ciliary body necrosis. Now, as well, these patients will often have intraocular findings that are consistent with advanced RB, things like hyphema, NVG, and vitreous hemorrhage. So how does all of this happen from a tumor inside of the eye? Well, it's not exactly known why there's this significant inflammation, but there are a few different theories. Of course, if necrotic tumor leaches out of the eye, that could cause a significant inflammatory reaction in the orbit. There's also thought that necrotic changes in the iris and ciliary body can lead to adjacent orbital inflammation, even if the globe itself is still intact, as well as invasion of subretinal and choroidal spaces, which could lead to this kind of orbital cellulitis as well. So again, the pathophysiology isn't exactly known, but just to briefly touch on it, there are a couple different theories. The first one being that the tumor just grows so rapidly that it actually outgrows its own blood supply. And when this happens, it becomes quite necrotic. And when there's significant necrosis of the tumor, these can leak and cause secondary inflammation. Now, another thought is that this kind of rapidly growing and large tumor could actually compress and cause acute vascular occlusion or thrombosis of the central retinal artery. And this would, of course, lead to autoinfarction, necrosis, and the whole cascade. And you might recall in our second case, there was a thought that maybe this child did have a central retinal artery occlusion. And this has been reported by Dr. Galley and the group at Sick Kids as well. And the thought is that it's essentially a bottleneck at the lamina cribosa. The tumor is compressing the area, which actually slows blood flow and leads to a thrombus formation. Now, just wanted to quickly touch upon the difference between aseptic and infectious orbital cellulitis, because sometimes, these cases can be tricky. And I won't necessarily go through the whole chart, but the kind of pertinent things to highlight are that in aseptic orbital cellulitis, you often won't have a fever or white count, whereas in orbital cellulitis, you would more often expect to see these things. And in aseptic orbital cellulitis, as you saw in both of our cases, the patients both had intraocular signs, whether it's anterior uveitis, hyphema, vitreous hemorrhage. Whereas in infectious orbital cellulitis, you wouldn't really expect to see these things. Now, this chart, these aren't hard and fast rules, but it's just things to keep in your mind if you're trying to think about which picture it might fit into. Now, interestingly, they can both have retrobulbar fat stranding on CT scans, so that isn't necessarily the most helpful way to decide. Briefly touching on the classification again, I won't go through it too much, but Group E is essentially these more advanced tumors, and aseptic orbital cellulitis automatically puts you into that group. And this is a very advanced presentation, which requires urgent intervention. And again, here's the aseptic orbital cellulitis puts you right near the top of the staging categories. And this, unfortunately does have quite a poor prognosis, and often these eyes you can't salvage. They often require enucleation. Now, to round off the discussion, just wanted to briefly touch upon the survival, just to highlight here that the red line here at the bottom is CT4 group, and the yellow line here is CT3. So the last child we saw actually was possibly CT4 because of that imaging that he had, but ended up doing quite well. And this is just to show that increasing tumor category translates to increased risk of metastasis and mortality. And if you break it down by subcategory, you can see CT3E of the 3 group is the most significant, and the 5-year cumulative survival is about 75%. And lastly, just to comment on the ability to save the globes, again, as I alluded to with CT3E eyes, especially this red line here at the bottom, the globe salvage rate is less than 30%. These are very advanced, dangerous eyes with a poor prognosis. So often there's not even an attempt to salvage them. Okay, so just to finish up here, a couple take-home messages. Aseptic orbital cellulitis is rare, but a serious presentation of RB not to be missed. There should be a high degree of suspicion in orbital cellulitis presenting with these intraocular findings. And aseptic orbital cellulitis does unfortunately have a poor prognosis, especially if the diagnosis is delayed. Okay, so that rounds off my talk. Thanks for listening to that whirlwind of aseptic orbital cellulitis.
Ellie, that was fantastic. Thank you very much. Question from Dr. Ostreicher about your first case, where there was a possible suspicion of an intraocular foreign body, and we performed an MRI. Was there maybe a X-ray done before that, or was the radiologist not so concerned about a metallic foreign body here?
Yeah, that's a good question. I mean, they had a CT from the referring hospital. I think it was low suspicion, given that during the EUA, there was no kind of entry wound or anything. And also the hyperdensities on B-scan were sort of multifocal. So it was unlikely to be an IOFB. But also, I think the lack of significant calcification was in part why the retinoblastoma wasn't higher on the differential initially.
Thank you. Those are fascinating cases. I mean, it's many of those I thought were going to end up being masquerades. So you got us pretty good there. Dr. Galley, you made a comment to the chat, but maybe you can make it to the whole audience, please.
Yes, I think a strong feature of both of these children, really well illustrated in a beautiful presentation, Ellie, is the acute onset of orbital cellulitis. All the other causes in your list of orbital cellulitis would not show that very dramatic acute over a couple of hours or even 1 hour emergence of such dramatic eye findings. And I think that's a very strong feature of the vascular occlusive events at the lamina curvosa, which we demonstrated years ago in that publication you showed, and I think is very clear in your second case as well. And maybe that was the real presenting feature too, in the case that also had extraocular tumor even at that point, but the acute event that brought him to the hospital would be the vascular infarct of the whole eye, essentially.
The interesting difference between these two cases, so both histopathologically had diffuse necrosis of the intraocular tumor. In the first case, he had extraocular disease. So probably, or we hypothesize that this kind of infarct that Dr. Galley is talking about, that acute event, probably happened after the tumor had already extended extraocularly. Whereas in the second case, it was sort of protective in a way that he had this auto infarct when he did, because the whole intraocular tumor died, preventing extension extraocularly. So he had a much different prognosis.
Could I also comment, I only remember one retinoblastoma where the lens dislocated, and that was slightly different, but might have been exactly the same etiology. This was a child with a very involved eye and went on systemic chemotherapy on day 1. And by day 2, the anterior chamber filled with blood. We enucleated that eye at that point, not knowing what had happened. We didn't have all the imaging capability we have now. This was quite a while ago. And the lens was actually at the back of the eye. So as the tumor responded dramatically, acutely to the chemotherapy, everything collapsed back, and the lens and anterior segment was sort of ripped out of the front of the eye, causing the bleed. But might be the same sort of dramatic mechanism.
That is interesting. I mean, these are all cases that any of us can see walking into our emerge, and to see them end up with a diagnosis of retinoblastoma is certainly daunting. There's no further comments or questions in the chat box. So I do want to take this opportunity to thank Dr. Galley and Dr. Kletke, as well as Mike and Ellie, for the excellent presentations today. And the team at Sick Kids, for managing all these patients, because this is a super specialized area of ophthalmology that many of us are not so familiar with once we get into practice. And we definitely don't see a lot of, but we're very fortunate to have the team at Sick Kids and the expertise of Dr. Galley and now Dr. Kletke, as well as the rest of the team there. So thank you guys for all that you do. A couple housekeeping notes. We don't have grand rounds next week. We have our annual resident written exam. And the week after is Walter Wright. So we will also defer grand rounds in lieu of that. So if you haven't already registered for Walter Wright, please do so. It looks like a great program. And I congratulate the team led by Dr. Slomovic for organizing a great meeting. So I hope to see many of you guys at Walter Wright, and we will resume grand rounds on December 9th. Dr. Kletke, I'll hand it over to you to close out.
Yeah, that's it for us. Thanks so much for having us. We really appreciate it. Thanks, Mike and Ellie. You guys did an awesome job. Thank you.
Enjoy your weekend, guys. Thank you, everyone.
Take care.
Great job. Thank you.
Thanks.